topic is LEMYERRE syndrome. Definition. LEMYERRE syndrome, also called post-anxiety, is a very rare complication of acute tonsillitis that is characterized by severe sepsis and the appearance of a thrombophlebitis of the internal jugular vein.
So here we'll discuss the case of a lady who presented with a right lateral neck swelling for 3 days. She said she had mild sore throat for 2 weeks previously to that, which was treated with antibiotics as per primary care doctor has prescribed, empirically for infection of the throat or whatever. Her oropharynx, when you look inside her throat, it was pretty clear, but she had an obvious non-pulsatile 3x4-inch mass on her right lateral neck. Next, I'm going to show you a picture of the CT scan of her neck. What is the diagnosis? Well, the diagnosis is LEMYERRE syndrome. So let's talk about that. Also known as human necrovasculosis and anaerobic post-anginal sepsis, is an uncommon condition in which colonization from an oropharyngeal source results in thrombophlebitis of the internal jugular vein, bacteremia with confirmation on at least one distant metastases. Occurring most commonly in previously healthy adults, the condition was first described in the 1900s, but fully characterized by André LEMYERRE in 1936. The most common pathogenic etiology of LEMYERRE syndrome is Fusobacterium. Necrospread infection is thought to occur by direct extension through the soft tissue into the ipsilateral side or the pharyngeal space. Transmission via oropharyngeal venous circulation and lymphatic spread via perivascular inflammation and extension and metastasis. The classic presentation of LEMYERRE syndrome involves peritonsillar disease, internal jugular vein thrombophlebitis, metastatic pulmonary lesions or septic pulmonary lesions, and isolation of Fusobacterium from a sterile body site, most commonly the blood, a blood culture. Secondary infection is most common in the pulmonary system, but can cause liver or spleen abscesses as well. Also, septic arthritis, osteomyelitis, meningitis, and cellulitis. Patients with secondary pulmonary infection may present with fever, rigors, dyspnea, pleuritic chest pain, and hemoptysis. The differential diagnoses include other infectious etiologies of bacteremia, other deep space neck infections, endocarditis, and aspiration pneumonia depending on the presentation. Vascular ultrasound or contrast CT scan is helpful to diagnose an acute vascular thrombus. The ideal diagnostic imaging modality to do for distant lesions depend on the anatomic location. Usually solid organs like CT scans, soft tissues, ultrasounds, and so on. If left untreated, LEMYERRE syndrome can result in local erosion through the vascular wall or disseminated infection, DIC, and septic shock. The mortality rate of LEMYERRE was reported as high as 90% before the advent of antibiotics, but now it's approximately 20%. That's still pretty high, as 1 in every 5 people with this. Metronidazole is the drug of choice against Fusobacterium, but mixed pathogens are not uncommon, so gram-positive coverage with beta-lactam agent is recommended. Prolonged antibiotics therapy is recommended to eradicate confirmed LEMYERRE infections. LEMYERRE syndrome is controversial, predominantly because the condition is rare and no good blinded control studies have been performed. The risk and benefits must be weighed against the potential complications of incompletely treating septic thrombosis. This patient had obliteration of the right internal jugular vein, noted to be highly suspicious for thrombophlebitis, LEMYERRE syndrome, on CT scan. She was admitted with IV antibiotics for treatment. She returned 3 days after discharge with recurrent neck swelling and was taken to the operating room for incision and drainage of the deep space neck abscess. That's a collection of pus. She was discharged on 3 weeks of antibiotics. Usually we put a PICC line, P-I-C-C, which is a long-term IV line for antibiotics, and then they're not retained to the emergency department, but treated adequately for this infection. So, why know about Lemierre syndrome? Mainly because proper knowledge of this kind of infection, one, will focus on which imaging modality you need to do, make sure there's no clots or thrombophlebitis of the vessels. Number two, look for metastatic infection sites in the lung, in the liver, in the spleen, and so on. And to give the correct initial antibiotic, suspicious for Fusobacterium would be Flagyl or Metronidazole. And finally, because you'll be smarter than most doctors who don't know what Lemierre syndrome is. I didn't until I started preparing this video. See ya.
Application in nursing. Generally, the Fusobacterium is sensitive to penicillin, although some species become resistant throughout the production of beta-lactam. So they also other covered clindamycin, metronidazole, anti-pseudomonas, penicillin, and penicillin sulbactam.
For today's EMN5, I'd like to talk about Lemierre syndrome. This can be a pretty tricky diagnosis with a high mortality, so it's something to keep on your differential to kind of rule out in your mind anytime someone comes in with a sore throat or any kind of complication from it. So let's start with a case to demonstrate a typical presentation. You have an otherwise healthy 19-year-old female who presents originally to her primary care doctor for a few days of sore throat, fever. So when her strep comes back negative, she's diagnosed with a likely viral pharyngitis and sent home with symptom control. However, about 4 days later, she presents back to the ER or her primary, looking slightly toxic with a fever, still having a lot of throat pain, now a little bit more right-sided than left, also having difficulty swallowing and a cough, looks a little dehydrated. So at this point, with the difficulty swallowing and the throat pain, you get a soft tissue film PA lateral of the neck, which in this case is unremarkable. Because of the cough and the fever, you also decide to get a chest x-ray, and this shows some significant findings. Several ill-defined nodular opacities within the right lower lobe and retrocardiac region. And now we start getting kind of suspicious for some kind of septic emboli causing these bilateral infiltrates. And with her history of unilateral sore throat, Lemierre's is starting to come to the top of our differential. So to confirm this, we get a CT scan of the neck with contrast, and sure enough, it shows an occlusion of the right IJ, and there is our diagnosis of Lemierre's. So just to give a very gross overview of this, Lemierre starts out as some kind of oropharyngeal primary infection, whether it's pharyngitis, tonsillitis, some kind of PTA, a dental infection, or even mono. That then results in spread from that primary infection into the soft tissues, which then leads to a platelet aggregation in the adjacent IJ caused by bacterial endotoxins. You end up getting a thrombus there, which then throws off septic emboli all over the rest of the body. The reason this is significant is because it has a very high mortality. Historically, it was around 90%, and today it still carries a 10 to 15% mortality, which in a young, otherwise healthy patient is pretty concerning. Lemierre's is considered one of the deep space neck infections, and it's something to consider anytime you have a deep space neck infection on your differential. Specifically, it involves the parapharyngeal space. So you can see here's your tonsils, and just adjacent to that is the parapharyngeal space. And in Lemierre's specifically, it penetrates the carotid sheath, and that's where things get a little scary. Inside there you have the IJ, the internal carotid, some cranial nerves, and also lymph nodes. That can easily lead to bacteremia. You can also get that clot formation caused by the exotoxins that I talked about, which then results in septic emboli. The most common in Lemierre's is to the lungs, the liver, the endocardium, and also joints. So let's talk about the features of Lemierre syndrome. Initially, you start out with your primary infection. So a patient has a history of some kind of neck or throat pain, tends to have unilateral symptoms, can be complaining of dysphagia, fever, chills, malaise. Next thing to watch out for is any kind of cough, dyspnea, pleuritic chest pain, hemoptysis. That's because 97% of Lemierre's patients end up having a pulmonary septic emboli. And like I said, look out for symptoms such as arthralgias, jaundice, any kind of focal neural symptoms, or altered mental status that could indicate septic emboli elsewhere. As far as diagnostics, for the initial primary infection and also the thrombus of the IJ, CT neck with contrast, and also ultrasound of the neck can be diagnostic. So here's an example of a normal IJ. And remember, we're really good at looking at this in the ER. We look at IJs all the time for central lens, so you should really be well aware of what this anatomy looks like. And over here you can see you have some clot, a lot of soft tissue swelling, and even some surrounding edema around that IJ. And CT scan, like we saw before, in this case it's on the left side. Here you can see that that's clotted off. As far as the pulmonary emboli, chest x-ray or CT chest can show it. And then just think about where else your septic microemboli are going. Things like EKGs, you might see a transaminitis or thrombocytopenia, a prolonged PT if it goes to the liver, and also think about any kind of septic joints, and of course if you have positive blood cultures. So as far as the microbiology for Lemierre syndrome, the big board-word answer is the fusiform bacteria. And part of the controversy in treating patients with the dose of penicillin for a positive center criteria, even if they have a negative rapid strep, is that you're treating for fusiform and therefore preventing Lemierre's disease. Other bacteria you see are oral anaerobes, Eikenella, strep pyogenes, and Bacteroides. Now, if this is an ICU patient who has an IJ catheter, think about staph or strep. So to treat Lemierre's disease, either Flagyl or Clinda to cover for the anaerobes, or you can do a penicillin plus beta-lactamase inhibitor. And if it is catheter associated, make sure you add vancomycin to cover for your staph and strep. Now, what about anticoagulating this clot? Well, that's pretty controversial. The recommendations I
Pros and cons. Lemierre syndrome is a rare but not exceptional condition that can complicate the evolution of an oropharyngeal infection, even if correctly treated. Etiology: the most common agent is Fusobacteria necrophorum, which is a common head of the oral flora, intestinal, and genital tract. It is a dry, anaerobic, gram-negative, and not spore-forming. Usually applied in Ecuador. Posentinium sexy due to was relatively common in the pre-antibiotic era, although it is currently considered a rare pathology with an incidence of approximately 1 million people per year. There was a record of publication of the subject Science. Conclusion: predisposing factors have been described for infection by Fusobacteria, consisting of the alteration of cutaneous mucus. Defense barrier that can occur is microvascular disease, trauma, surgery, and even pharyngitis caused by the Epstein-Barr virus. Thank you.